Hi, I'm Brianne Bell, and I'm going to talk about our project to predict heart disease based on various factors. We're going to talk about relating to heart disease is resting blood pressure. That's just the pressure of your blood on your arteries when it's pumping, when you're at rest and not doing anything. When you're fasting, blood sugar, if it's above 120 after not eating or drinking for 8 hours, indicates you have insulin resistance or insufficient insulin production. And that usually means diabetes or prediabetes, which is a very common disease to have with heart disease. And lastly, the echocardiogram, which you can see in the image on the right, gives a graphical representation of what's going on when your heart is pumping and blood is flowing. Our main terminology is just a Jupyter notebook, which we'll utilize to develop, document, execute our code, and communicate our results. So a little bit of background. Heart disease is just an umbrella term for various diseases of heart muscle and heart tissue and blood vessels and the electrical system of the heart. That being said, the most common is coronary artery disease, which is a blood vessel disease, and overall heart disease, just in general, just with all of those types, is the leading cause of death in the United States. This is because heart disease often leads to strokes or heart attacks as their main potential consequences, and those are considered adverse events and they are also very, very bad for the patient, and they're also very expensive to deal with. Brianne et al., a group that studied an education program as a means of making treatment more economical, found that having this program decreased the occurrence of heart attack and stroke because it educated the patients more. So ultimately, the model we are using or developing could be utilized to develop an educational program that could further decrease the cost to the insurance companies. In terms of objectives and success, we want to have a fairly accurate and precise model that limits the number of false positive or false negative diagnoses of heart disease. And as time goes on, as more knowledge is developed for heart disease and other medical conditions that either cause or are affected by heart disease, we'll have an open-ended model that can incorporate those factors to develop more complex models of predicting. Overall, the main goal is to save the insurance company some money. In terms of how accurate we want it to be, we want our model to be at least 92% accurate when it's released to the insurance company and clinics. And we want to continue to collect data and develop more secure ways to store the data. Some assumptions and constraints is just how the data is getting to us based on a voluntary agreement between the patient and the insurance company. And we are also assuming that there won't be any missing data points. If there are any that are supplied, we will likely just exclude those until a less exact model is made using those, or until more complete data is supplied. In terms of the resolve strategy, we're going to look at how heart disease is the leading cause of death in the US and the cost of heart attacks and strokes. Here, some issues that may arise is the reluctancy of the patient and clinic to participate. To get around that, we plan to educate the clinic and patients and supply consent forms so that they understand how their data will be used and how it will not be used. We also plan to incorporate the legal team so they can provide some ethics supervision and provide any input that the data scientists may not realize. Overall, this should have an outcome of improved communication and data security, as well as the model that we are developing. And it'll also have an impact of improved trust, communication, and knowledge between the groups, which is a value that our insurance company holds highly. So, in order to tackle these, we will have our consent forms that are annually released. We could combine those with the consent forms that are already released to patients. In terms of risks and contingencies, there is always the risk of the data being insecure, so we're going to use the most secure systems we can and utilize randomization measures to keep the identification information safe so that only the clinic has access to that. And in terms of incomplete data, we will just skip over what is incomplete and utilize it at a later time. And a financial risk is when this model proves to be successful, if we want to further explore other factors, we would have to go back and collect additional data for the same patients. A way to get around that would be to have additional data that won't be used initially, but will be added on later as more complex models are created. So, like I said, the goals from data mining and just from the study in general are to have a maximized model for accuracy and precision, and to utilize a chi-square test for statistical significance, just to be sure that our methods are significant for this study and can be utilized in other studies for other diseases or more complex versions of heart disease studies. Overall, this process will take about 59 days. It could take less if the modeling and evaluation take less time. Then, for the data that we are going to look at initially, it'll be the sex, whether your fasting blood sugar is above 120, and if there is exercise-induced angina. Additionally, we'll look at the chest pain type, the resting EKG results, and the thallium stress test results. Other factors are age, resting blood pressure, the maximum heart rate, number of blood vessels colored by fluoroscopy, and some select measurements from the ECG that are typically indicative of heart disease. From what we found in the data so far, is that a lower maximum heart rate typically is reflected in heart disease, whereas a high resting blood pressure is also indicative of heart disease. Interestingly, of all the factors that we looked at, as you can see in the heat map, there isn't any factor that has a very, very strong correlation, but there are many that have moderately strong that could prove to be the most beneficial factors to look at. And overall, from the data, there's 14 columns, as we discussed, of the different factors we'll look at, and of the initial data set supplied, there are 270 rows, and there aren't any missing data points, so we won't have to exclude any data points at this time. And these are some of the references we got our information from, with the Cleveland Clinic reference being for the image of the echocardiogram.